neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
In easy terms, it's basically a doctor-controlled robot performing your surgeries. It's become the standard of multitude of surgeries and operations around the world, and we're going to talk about it tonight, some specific questions. How did it first start? Where are we now? And when is there never going to be a doctor in the operation room? I don't think that's ever going to happen. But these are questions that people are asking. During this next hour, we have questions that you can ask us live at 881-0013. If you have to leave your television, you can also stream us live. This is streaming live on youtube.com, and just search for El Paso Physician Live, and it will be going on live, and you can ask questions there again too, 881-0013. This evening's program is underwritten by the Hospitals of Providence, and we also want to thank Texas Tech Paulo Foster for providing students to answer our phones. And I want to say very much a welcome to you. This is our 25th anniversary of the El Paso Physician, and a big kudos to the El Paso County Medical Society for hanging in there that long. I'm Catherine Berg, and you're watching the El Paso Physician. It's interesting because I'll have some of these doctors on the show, and yeah, they're doctors, but I've known them for 20 years. We've been doing the show for 20 years. You know, he talks about farts, and he talks about diarrhea, and he talks about all kinds of things that nobody wants to talk about. And that's what's great about the show, because you get to hear those things on the show and go, I'm not the only one. It's great. It's the El Paso Physician. The docs in the studio did not get to hear what that audio was all about, but I think it's always fun if you can say on live TV, you can talk about farts and diarrhea, and people think, oh, that's okay. I had 2 giggles here earlier. So with me, we have 2 veterans and a newbie, but I think this is going to be great. Dr. Richard Farnham is gynecology. He's with us this evening, and I remember you just doing all kinds of stuff with the Da Vinci system for many years. Then we have Dr. Chiba, who is abdominal surgery, which includes all kinds of things. And then we have Dr. Antonio de la Rosa, OBGYN. And the first show that we did about robotic surgery, you were on that show in 2007. So I just kind of went back and did some of our research. So it's kind of interesting to see what is going on now compared to what was going on 9 years ago and 10 years ago. So we're going to have a lot of discussion this evening. And what I'd like to do is start off with each one of you. And since Dr. De La Rosa, you're right next to me, if we can just tell the audience what your discipline is, what you do all day, every day. That's kind of my way of introducing it. And that way people at home know which doctor to ask which question of, if that makes sense. So Dr. De La Rosa, you get to start. You can even go back to the show in 2007, what you remember from it. Was it good? Was it a good experience?
Yes, it was.
Thank God, because it only took you 9 years to come back.
Yes. Well, I'm an obstetrician gynecologist, so we deal with women's health. As far as the Da Vinci robot goes, we do gynecologic surgery, including things like hysterectomies, ovarian cystectomies, pelvic support surgeries, as such.
Okay. And then Dr. Chiba, as an abdominal surgeon, I know that includes a lot of things, but you were saying earlier that you specialize in weight loss surgery and what was it else? Weight loss surgery and just general abdominal surgery, but what does that mean to the audience?
Yeah, so my training is in general surgery, but there's extra fellowship to train for weight loss surgery. We call it bariatric surgery. Also including in the fellowship is robotic surgery as well. Mm-hmm. So abdominal surgery would be a gallbladder, hernias, incisional hernias, appendectomy. Some of them are emergencies as well, which can be treated with robotics as well. And then you have bariatric surgery, which is weight loss surgery. The most common surgeries, sleeve gastrectomy and gastric bypass, and I perform those in robotics as well.
Okay, and I'd like to get into that a little bit too, because I know that there's still questions on the sleeve and bypass and which is better, what's being used more. It's a little bit shifted throughout the year, so that's going to be interesting. And Dr. Farnham, you do anything gynecological and urinological. That's not a word, but in that whole realm, we're going to make it a word tonight.
That's it.
But if you can explain to the audience at home what you do, including all your conferences that you go to, goodness.
Well, yeah. So, like Dr. De La Rosa, I'm an OBGYN, trained in that specialty, and did a fellowship in specifically minimally invasive surgery, so doing things through small incisions, which is what we're talking about tonight with robotics, and board certified in female pelvic reconstructive surgery. So the urinocologic.
Gynecological.
So it's basically
yeah,
urology.
That's our made-up word for the night.
That's
yeah,
right.
It's basically urology. Yeah.
Urology for women.
Yeah, there you
So
go.
prolapse, incontinence, conditions that are frankly epidemic. A third of women have it, but no one wants to talk about it.
Bingo, and that's why we're here. And that was kind of what that promo was about. This program is about stuff that people are, uncomfortable speaking about. And so, especially the female form, once we get a little bit older, literally one of the big questions is every time I go in, it's like, are you leaking when you cough? And I'm thinking, what does that mean? And then you start realizing what they mean. So these are questions, and that's why we have a live program here. Dr. De La Rosa, I'd like to start with you. And going back to 2007, fine, but explain to the audience what robotic surgery is. I remember back then we were talking about it and it freaked people out. It's like, is there not a doctor in the room? What's going on? If you can kind of explain what it is, and then we've got a video that we're going to queue up in a few minutes too, so people can kind of see how the hands work.
Okay, well, things have changed a lot since we were last year.
They have.
Robotic surgery lets us do minimally invasive surgery a lot easier. You could think of it as a tool. A lot of people know what laparoscopic surgery is when we do surgeries through little small incisions instead of a big abdominal incision. So what the robot lets us do is do more complicated procedures. In that way, we get specialized instruments, we get better visualization. There's a lot of safety mechanisms involved that help us get better outcomes. Going through small incisions lets us do surgery with less pain, less bleeding, less chances of infections too. Just the bigger incision, the more it's going to bleed, the more it's exposed to the outside elements, so there's also a higher rate of infection. When we first started robotic surgery, I mean, it was fairly new. Not a lot of people knew about it, but now it's pretty much become the standard of care. And also, I mean, there's a lot more. When I first started, we were pretty much just doing hysterectomies, simple cystectomies, and now we're doing a lot more complicated procedures like the pelvic organ prolapse surgeries, which are a lot more complicated. Now this allows us to do it and get patients home sometimes the same day, and instead of being in recovery for 2 months, they're getting back to work in about 2 weeks or so.
Dear Lord, 2 months it used to be?
With a big incision, yes.
Yeah, that makes sense. And I remember, just visually, I don't know if it was you, but one of the doctor's hands back in 2007, they were showing the cameras, like, do you see how thick my fingers are? And then immediately they came in with a little tiny tweezers when you're looking at trying to tie stitches inside the body. And I thought, that's brilliant, So again, we were trying to talk people into the idea that this is good, this is an awesome thing. Again, it was freaking people out, but now it's so great, and so many things that have come into play. Dr. Farnham, there is a video, and Gracie, if you don't mind running this video in the back, there's a video, and if you don't mind just kind of talking over it.
Absolutely.
Of kind of what the surgical room looks like when you're in there and performing a robotic surgery. And there we go.
Since it came out as the standard SI and now the XI. So these are my hands. They're working on these joysticks basically that are in this robotic console that I'm peering into, and I'm operating in a corner 15 feet away from the patient bedside. And essentially, these arms hold the camera, and the robot is a giant marionette, and it holds all of the instruments and all of the movements that I make in space in this little console area are miniaturized inside. So a movement of 10 centimeters in space here is a movement of 1 centimeter space on the inside, making it much more precise. And this is actually a case observation we did. We had a surgeon, Proctor, come from Maryland, I believe, on this one. And so she's trying to advance her skill set. She's trying to learn more procedures. And so we at Trans Mountain are the only epicenter training site in all of Tenet, all of the Providence Health Networks, but actually in the country in all of Tenet. And so
really?
this is the destination site where surgeons will come to learn the robot in general, and then also as they move along in their learning curve, take on more complicated procedures.
Well, I'd love to transition that into, to me, one of the most obvious questions is training, training, training. I did not know that about El Paso. Just one more high five to El Paso on that one. And Dr. Chiba, I'd like for you to kind of take it too, because we have two OBGYNs here, and then we have general surgeon. You're concentrating on abdominal surgery. But Dr. Farnham, if you can start off on these trainings, because again, you go to conferences because you are helping train other people, and then you also go to get trained in other conferences as well. Explain what kind of training everybody needs. So I know that there's 4 hospitals of Providence robots, so each campus has a robotic system. Like you said, there's generations of them now, but how often do you go to trainings? How often do things change? When do you bring the Dr. Chibas in, et cetera? I mean, how does that all work?
And that's a good point. There's a lot of collaboration for what we do. On Tuesday, I collaborated with Dr. Javier Arenas from urology to do a case where a patient had a ureter that was obstructed and from endometriosis. So that falls under the GYN category, but then it had to be transected, removed, and then reimplanted into the bladder, which goes to urology. And as we saw there, not only for teaching purposes, but with that dual console, both surgeons can sit and just hand instruments back and forth to one another to have a completely integrated, correlated, surgery. And
so you have an OBGYN person that specializes this, and then a urologist, and or somebody else that specializes in whatever, and you can all do surgery at the same time. When I say all, 2 of you can do surgery at the same time.
Exactly right. And I haven't worked with Dr. Chiba yet. I've worked with your partner, Dr. Eng, where we've done cases together that may involve bowel disease. So we can talk about endometriosis all night, but it's a condition that women have that causes painful periods, many times debilitating painful periods. And it's a disease that originates in the uterus, but it implants into the pelvis. And it can go anywhere. It can go on the ureter, as is the case we mentioned. It can go on the bowel. And sometimes we would have to have a combined case where we remove some of the disease, and then the general surgeon comes in and sews up the bowel, or sometimes even removes a portion of the bowel.
Goodness. And Dr. Chiba, as far as your training goes, when did you first get into this? I mean, was it, you look like you're 12 years old, which means I think it's always been there since you're around. But seriously, when was this something, again, 2007 is the first time I really got involved in any knowledge. Granted, it started before then. But just in general, how was your training? And was it ever a question that this is what you would do surgeries with?
Yeah, when I meaning residencies where I trained to become a general surgeon. It was, robotics was still new. We only had the first SI system, the first robotic system. So my bosses were actually learning. So I was bedside learning with them. Now come fellowship, that had changed a lot. Now at that point, a lot of surgeons, general surgeons, bariatric surgeons are already capable of doing robotic surgery. So at that point, I learned a lot of robotic surgery, and that's where you get a certificate for a certain number of cases, and with that certificate, you're able to operate using the robotic platform.
And Dr. De La Rosa, I know that Dr. Farnham said earlier before the show that you were the first person that did, I forgot what you said, ABC surgery. What was that? And do you remember doing that, your training before that? Because were you the first one doing OBGYN surgeries in town? Do I remember that correctly?
The first gynecologist that utilized a robot.
Okay.
And back then, the training's gotten a lot more sophisticated as we've gone. Back then, I did laparoscopic surgery, so I was transitioning from using my own hands to direct instrument to using the robot. And the robot's like a tool. You could kind of compare like an electric screwdriver. You could do it manually, or you could just use the power.
Make it more precise,
it's supposed to make it, and it's supposed to make it easier. Back then, I had to go to a training site. Well, first we did case observations. We went to a training site. There was a lab, an animal lab, where we learned how to use a robot, how to use the instruments, just how to work the robot without doing surgery. Then there was an animal lab where we actually did surgery on specimens.
Right,
after that, we had to get preceptor for our first cases, so they would get more experienced physicians to come in and guide us through the surgeries. And you had to get a certain number of cases, and after that, a certain number of cases that they would review, make sure you were doing well and you were progressing fine, and then from there you'd get your full privileges. Now a few things have changed. the labs and all that they do are more, I guess now they have cadaver labs and stuff where you actually do surgery on human cadavers. There is simulators where you could do like virtual surgeries.
I'm a pilot, and all this associates with the same thing.
Yep.
You have so
And
many
it's
hours
very
that you have to
similar.
have, then you go over here, and then you get this certification and that certification.
There's
So, yeah.
there's a simulators, the dual consoles now in residencies. Now a lot of the residents are coming out trained, and your faculty sits next to you and just guides you the whole way.
So that is part of medical school training at this point, for the most part. The robotic system is, if you're
At
going to
this
go
point.
into the surgical field.
Yeah,
Okay.
now it is. Yeah.
Okay, now it is. I
Now
like
it
the way
is.
you said that.
Yeah.
Okay. What I'd like to do too, I was just looking at Dr. Farnham. What was I going to ask you? So let's talk about, you were talking earlier about pelvic reconstruction. So I'd like to go OBGYN, then go to abdominal for a while. But when you're looking at, and this is females obviously, but there's a lot going on inside the female body. Lots of, we can start with babies and really go to someone who's 45, 50 years old. What has happened to the different organs now, the reproductive organs? Let's talk about urology. Let's talk about just different things that you do. And maybe if you need to pass it on to urologists too, but things that you're specializing in with this system.
Well, I think, as Antonio mentioned earlier, the breadth of what we do now with robotics is unrecognizable from what it was in 2007. In fact, when it came on, there was a lot of pushback that, oh no, you know, this is this new technology. How do we know it's safe? How do we know it's effective? And there actually is a lot of literature now that specifically shows that robots are actually better. There's level 1 evidence that shows you get fewer conversions. Meaning that you are starting out with little holes, little incisions. You're less likely to do an open incision by the end of the case if you use a robot as opposed to doing laparoscopic or
Right.
straight stick
Right.
or laser surgery. So there are, and endometrial cancer node counts are higher with robotics. It specifically has better outcomes for morbidly obese patients. So as we get further and further out, we're collecting, I mean, besides the obvious, that, you know, you look into a console, you can see 3D. You can't do that laparoscopically. You have to look at a screen that's a 2-dimensional screen and try to create a 3D perception in your mind. I mean, you guys all have done this. I mean, you went through that experience where, as a surgeon, you have to kind of create the 3D image in your mind from a 2D screen. You don't have to do that with robotics. That's given to you.
Right,
It's more
right.
precise. There's the motion scaling. There's the tremor reduction. So there's a lot of just obvious advantages. And at its simplest level, I would say robotics is computer-assisted surgery, right? We all live
a good way of saying
computer-assisted
it.
lives,
Right.
right? I mean, what would we do if we didn't have our iPhone in our calendar? So it's just taking the surgery that we would do laparoscopically and just making it more precise. So, and I'll say one other thing is that it got a lot of pushback when it came into OBGYN. And what we did see, though, is we saw the number of open cases, meaning that someone get an open incision that we talked about here, where you have a long recovery, for the first time in history, dropped below 50%
Oh,
with the
wow.
introduction of robotics.
Right,
And
which
now-
makes sense.
Right.
Right, of course.
And now it's not the plurality, it's actually the majority of all hysterectomies. 51% are now done on the robotic platform. So some surgeons think, oh, you know, I'm too good for the robot, I don't need that, it's a fad. Well, guess what? It's here to stay.
Right.
So the surgery on a abdominal or pelvic organ, so you know, appendixes, hernias, hysterectomy, tubal ligation, ovarian cystectomy, smoking, heavy lifting, the connective tissue that supports the pelvic organs, the bladder, the rectum, the vagina, becomes weak, and these organs can actually start to descend. And you know, as you shared in your anecdote, why are people asking me if I leak? Well, that's
But,
why.
and this is
So-
where we talk about it. Let's make people uncomfortable. You
Right.
know, they're sitting at home or wherever they are, but explain why the organs do that. You know, that would be part of this show.
Well, and again, the biggest risk factors are going to be obstetrical risk factors, vaginal deliveries, particularly instrumented deliveries. Those are going to have statistically significantly higher risk for the future development of prolapse. Now, prolapse, no one comes to my office and says, hey, doc, I have a grade 3 prolapse. How can you help me?
How does one know?
They don't.
Right.
So it's, I feel a bulge. I feel like I'm sitting on an egg. I was in the shower and I felt something. These are the common things that will come up. things that will resonate with patients if you ask. And then just as part of annual women's health care, we're going to do a clinical exam, and maybe they don't want to talk about it, but you'll
because
see
they're
it.
embarrassed about it. Right, right.
And then you have to have that conversation. Does this bother you? And it's okay. I mean, this affects a lot of people, and there are very effective treatments. Now, it doesn't have to be surgery.
Right.
There are pelvic floor exercises. There's pessary devices. But for those patients that have suffered with it, and particularly for urinary symptoms, incontinence, coughing and leaking, urgency, running to the bathroom, not being able to empty their bladder. Some patients never leave their house.
Oh, gosh.
Because they're afraid they won't be able to find the next bathroom.
Right.
And, not necessarily robotic, but there are treatments for this. And,
So what are you doing physiologically in the body then? So you're talking about the ligaments that are holding these organs there. So during the surgery, not hysterectomy, but say a bladder, are you lifting the bladder? What are you doing inside the body that's helping in that situation?
Yeah, so there's 3 levels of support. There's the upper support, which is the uterosacral ligaments. There's the level 2 support, which is the arcus, tenuis, fascia pelvis. But they're just different layers of connective tissue. They become weak and sometimes even break away.
There you go.
During
yeah.
delivery.
Okay.
And there's no more support, and so they then fall, and gravity pulls them out through the opening in the vagina.
And usually that takes years and years, but if you feel something,
That's right.
just definitely ask. I mean, for the most part, we're hoping, for the most part, everybody has an annual exam anyway, women especially in that way, but just ask the questions, right?
That brings up a very good point, because so many people, but women, kind of missed out for years because of the pandemic.
Right, good
And
point.
now they're coming in with more severe, and you probably see this in general surgery too,
Right.
that patients have waited too long, and things that may not have been as critical or severe, we're seeing more acute problems now coming out of the pandemic.
And that's a great point. And going to Dr. Chiba, when we're looking at weight loss surgery, I'm just trying to think of some of the things that you specialize in. That is an elective surgery, so to speak, And coming out of the pandemic, I'm assuming that there's more and more of that happening. But when you are doing robotic surgery, so you were talking about the bypass and you're talking about the sleeve. Both of those you do robotically?
Yes.
Is that correct?
Yes.
If you could just explain to the audience what you're doing. I think sometimes they're just curious as to, well, what does the sleeve bypass do, and what does the sleeve or bypass do? I know I'm talking about the same thing with 2 different words, but
Yeah, so sleeve gastrectomy is one of the most common procedures for bariatric surgery now.
and is that the one that has been for a long time? Like, which
No,
one came first?
So bypass is a little bit more older
Okay, bypass
operation.
was the old. Okay, gotcha.
I kind of have tested the times, and
Okay.
it is a great operation. A little bit newer operation is called sleeve gastrectomy.
Okay.
And it's one of the most common bariatric surgery performed in the U.S. now. About maybe more than 80% of bariatric surgery is sleeve gastrectomy now.
More than 80%
Yeah.
is. Goodness.
Yeah.
Okay.
Depends on the
Okay.
area, but majority.
Okay, I know that usually when we have that show, we've got a great video that kind of describes what's happening there. But if
Yeah.
you can describe just verbally to the audience, what are you bypassing
Yeah.
when you talk about the bypass surgery, and then what do you mean by the sleeve?
Right,
If you
so-
can just kind of describe it for the mind.
Right, so sleeve gastrectomy is basically creating a banana out of your stomach. Your stomach is basically a bag that you store food for digestion. You resect about 80 to 90% of your stomach, so it becomes more tubular. So one, you can't eat as much. Number 2, there's actually a metabolic effect that happens, and your metabolism actually stays high even though you're losing the weight. Typically, when you lose the weight, your metabolism goes down. So it's much easier for you to gain weight again.
Right.
But with bariatric surgery, your metabolism stays high to keep on losing that weight over the first year and a half. Now, gastric bypass is a little bit more complicated operation. Initially, you create a small pouch. So basically, your stomach becomes the size of your thumb. You connect a piece of intestine to that. So now the food goes into your small pouch. We call it the gastric pouch, and then goes directly into the small intestine.
Gotcha.
And then you bypass about 125 centimeter of small intestine. So, and then there's another connection a little bit later. I know it's a little bit complicated, but another connection where the digestive enzymes come in. And the food and the digestive enzymes meet there, and the absorption starts there. So one, you can't eat as much because your stomach is extremely small now. And number two, there's a malabsorptive component where you don't absorb food in portion of the small intestine. And then there's that metabolic component as well, where your metabolism stays high.
Interesting. And then I know after that there are just different nutrient situations that you need to pay attention to going forward. What I'd love to ask at this point is, because this show is really about the robotic system, is using, when you're talking about connecting this, disconnecting this, connecting this, which makes sense. I mean, I get it. But this is where I feel like it's so cool to have this system that has these little tiny tweezers that are doing the stitches. Because when you're disconnecting and then reconnecting, I feel like that's something that we can, give a high five to the robotic system for. Like, how many stitches are there that are connecting? And how is that stitch done? Is it one continuous stitch, or just how does that work when you're reconnecting things?
Yeah, so different surgeons do it a little bit differently, but I typically use a stapler to make the connections. But you still have to close that hole that you put the stapler in. And when you're using laparoscopy, you technically you don't have a wrist. So with robotic surgery, you have an extra axis where you can turn. So your suturing becomes much more smoother and more controlled.
Okay.
So imagine trying to suture with like a crab versus having that wrist like a human being.
Right.
So it kind of imitates open surgery, actually, adds the laparoscopy with the benefit of open surgery, which is wristing.
And I'm sorry, I just got a question from the audience. So, and when you were saying that too, and Gracie Torres is in the back. Eventually, what I'd like to do, Gracie, if you don't mind, is show that video again, because we showed it at the beginning of the program, but it does really describe and show when you're doing your wrist movement. So we'll definitely show that in a little bit. But a question here from the audience, and it's perfect that we have Dr. De La Rosa, who's next, is the question: what is the removal process for a hysterectomy? And so this is a great question, because there's a lot going on there too. And then there are organs that are moved out of the way because another organ is now gone. And then now the organs come back that, find their room again. If you can kind of explain all of that, because people hear the word hysterectomy, but don't really know what that means. They just know it's something that old ladies have, and I'm one of the old ladies, so I don't have a hysterectomy. But in general, I think that's just a question.
Well, a hysterectomy is the removal of the uterus. That's the womb where a baby lives when it's growing.
Right.
Okay.
But it takes up a lot of room.
It does,
right?
and there's there's different sizes. If they have fibroids, they get enlarged. They could be some hysterectomy. We remove uterus the size of a 5-month pregnancy sometimes.
Oh my goodness.
And I get that patient a lot. I get that question a lot from patients. Like, you're doing the surgery through small holes. How do you get it out? So there's two ways. There's two ways that we usually go about it. One is, a lot of times, once we detach the uterus and the organs, we're able to pull it out vaginally. I mean, that's how you have a baby. It's simple.
It's the most natural way.
Once it's out, we close the opening that was left in the vagina. And sometimes when we get those big, huge uteri, I mean, even those are impossible to get out in that route. So there's different techniques, but a lot of times, what most of us do is these small incisions, we might have to extend them just a little more. I typically use 4 incisions less than 1 centimeter. And
I'm going to stop you there, because I think it's interesting to know where those incisions are placed. So if you're thinking about the abdomen, explain to people at home where.
I use 1 at the belly button, 2 lateral to that on one side, and 1 lateral to it on the other side. Okay. They're all 1 centimeter
Which is
big.
Amazing.
Yeah.
I mean, really, just a little.
Now with a larger, my technique, like I said, there's different techniques, but I usually extend the umbilical incision to about 4 centimeters. And there's a variety of endoscopic bags we could put into the pelvis. So we basically put the specimen in the bag, get the top portion of the bag, pull it out through that incision that we extend out a little, and then we pretty much just pull out the specimen chunk by chunk. We cut it up.
Chunk by chunk.
Yeah, and the reason we put it in the bag is so we won't lose any part of it. There's nothing left behind.
I remember when laparoscopic surgery was first a thing, that chunk by chunk. I mean, granted, that in and of itself in the day, again, this is the 25th anniversary of the show, right? So back 25 years, really? You're just doing little scopes on doing this? But the idea of removing a larger organ from the body in these small incisions is, to me, absolutely amazing. We have a question, another question here from the, oh, that's nice. We have a call actually from Riverside, California. So YouTube is working.
Nice.
Yay.
Right.
So we're streaming live.
Go Riverside.
I will give another plug on PBS El Paso show of El Paso Physician Live. If you go to youtube.com, just go to El Paso Physician Live, and you'll get the show and you can ask questions, which is great. The training, we were talking about training earlier, and if there is specific trainings for GYN, for bariatric surgery, for, and maybe, I don't know this, but can you do robotic surgery on, let's say, joints, or what other areas, maybe that's more the question, what are other areas aside from the abdomen and gynecological reasons, what other areas are the Da Vinci system being used on? And I'm just throwing that out to anyone who wants to take it.
Well, I mean, Intuitive Surgical is the maker of the surgical robot that we all use. That platform is for abdominal pelvic surgery.
Okay.
It's also been used and being used currently for thoracic surgery to
It is, okay.
Treat pulmonary tumors, lung tumors, even cardiac surgery. In fact, the CEO, Gary Guthart, for the company, originally their goal was to have this platform for thoracic surgery. Because if you're talking about a reduction from 2 months down to 2 weeks for abdominal surgery, imagine not breaking the sternum.
Bingo, 'cause you're talking about this
6
whole
months
rib cage.
down to a month
Right.
or two for recovery.
Goodness.
And interestingly, and again, the hospitals of Providence brought the robot to El Paso, and it was a urology robot at that time. And so Gary says, you know, we aim for the heart, but we hit the prostate.
Very nice.
But that was what the robot was used for. But yeah, any abdominal, pelvic, even thoracic now for the Intuitive robot. They have a new robot called Ion, which is for pulmonary biopsies. So without actually going through incisions on the abdominal wall, just down the throat, you can biopsy tissue that way. And there is a platform called Single Site, and it can be done all the robot arms through one incision in the belly button or through another natural orifice. There's transanal, transoral surgery. The ENTs have found a role for that as well. And then there are other platforms, and I think most recognizable one is the Mako robot, and this is for joints.
Mako, M-A-K-O? Okay. And it's for what? I'm sorry, joints.
Orthopedics, for
I
joints.
see, okay.
Now that being said,
That's interesting.
there are 7 other companies that have robots coming to the market in the next 24 months
Goodness.
to compete directly
Right,
with the Intuitive robot. But you know, it's a process, and they're 20 years ahead. And so we'll see, you know, who the winners and losers are in that process. But for the foreseeable future, it'll be Intuitive. And I would say that the training process that we're talking about, so you have to do didactics, online learning, you have to go and do a lab, then you have to get a case observation, then you have to have somebody observe you. If you think about any other instrument, any other technology in the OR, what's the training pathway for the surgeon? I want that. That's it. That's all they have to do.
Right.
So to have a company that has created this longitudinal relationship where you have access to these learning opportunities. So, I mean, the next 12 days, I'm teaching courses in Houston, LA, Tampa Bay, and Maryland, I think. So, you know, there's a lot of demand for advancing. You get to a plateau and you're like, well, what else can we do with this technology? And I would say, however good you are laparoscopically, I can make you better with a robot.
Right.
It's just,
Well,
it's
just like I
intuitive.
said, it's these little tiny precision, and I think that's probably one of the best words. Dr. Chiba, I'm going to ask you as a general surgeon. We've been talking a lot about the abdominal area, yes, and that's what you concentrate on. But as a general surgeon, when you were training, when you were learning how to do this, because we did talk about other systems, as you had said, were there other systems that you were interested in at what time? You know, whether it was joints, thoracically, I can see that makes perfect sense. If there's a way not to open up that rib cage, in general?
No, the only robot that I've been able to use is Intuitive. So
Okay.
even from the first robot that I got on was Intuitive.
And so when you describe intuitive, and I know Dr. Farnham, you said that a couple of times too, describe the word, like what's the definition of an intuitive robotic situation versus when we were talking about joints? When you're saying intuitive, that it kind of, not that it reads your mind, but when I think intuitive, it's like, well, it's just a natural thing that your mind knows how to do. So describe what the word intuitive robotic system would be versus another robotic system in surgery. Is that it's a hard question, right?
good marketing.
I'm trying to, is it just marketing?
Good marketing.
Yeah, the robot, it's called Intuitive Surgical. That's,
Okay.
that's the robot.
Great, because I'm just thinking,
It's
like,
true,
well,
though.
well, how can it be intuitive on its own? Because either way, you guys are operating it on the outside. So, but you said the only robotic system that you have is abdominal and intuitive, so to speak.
Yes.
Would you ever, because again, I'm looking at you like you're 12, you've got 100 years still to go. Are you interested, because I'd like to talk about the future, and I want to ask you some questions about the future too. Would you be interested in other surgeries as a general surgeon of different systems that aren't abdominal? And how do you foresee that coming about?
Well,
Like a knee replacement, for example.
Yeah,
I know it's laparoscopic, but
right. Those are used by orthopedic surgeons, so I would not be using those joint.
right.
But yeah, as even the orthopedic surgeon robot gets better, maybe that technology can be used in abdominal robotic surgery as well. So I think just in the future, you just have more technology and you can apply that onto the current robot system and just make it better and smaller and improve the robotic platform and the whole laparoscopic platform, basically.
you know, I still picture, for those of us that are old, Star Trek. And there was it Bones? The guy that the doctor, he would just go over somebody's body and fix things. You know, sometimes I feel like that's a place that we will be 50 years from now. And I think just the robotic system starting us off with that is where we're gonna be eventually. Dr. De La Rosa, just because I look at you and remembering your face being one of the people that I interviewed regarding this, where do you see, with your practice with OBGYN, where do you see robotic surgery being 5 years from now? We can look at 10 or 20 years from now, but just 5 years from now, because I think that's realistic to see with you know, the trainings that you're doing right now.
Well, my specialty, I mean, like I said, it's pretty much becoming the gold standard. I mean, there's still people that are, it takes dedication to get trained and become proficient. Some people haven't gotten to that point, and you always hear you can't teach an old dog new tricks. So there's some people that are more hesitant. But even our college, ACOG, American College of Obstetricians and Gynecologists, they're saying that they released a statement that if you can't do a minimally invasive surgery, you maybe should refer to another physician that could. So I mean, that coming from our own college is a big statement. So I think, and now that we have it in residency programs, it's pretty much becoming standard. Pretty much everybody's going to be doing it in our specialty. Now, we all have different areas of expertise, and even within OBGYN, we have fellowships and people specialize even in greater, so everybody will have their place, but it's just gonna grow and grow. And another thing that sometimes we don't mention is, as a surgeon, I know a lot of people that were kind of slow to adapt it are now coming along, because you don't realize how much of a toll surgery puts on our body. A lot of us have back problems, neck problems.
Right, and you're bending over for hours on end doing surgery.
So two benefits. It protects our back and neck. It eliminates fatigue, and sometimes you think that's just a benefit to us, but even for patients, it becomes a benefit, because first question I get asked a lot of times in the morning when I go see the patients is, "Did you get a good night's sleep?" You know. So when you have five, six, when you have 5, 6
Drink
cases,
last night, party, what's going on?
When you have 5, 6 cases in a day, your last case you want to be as fresh as you were your first case, and that even eliminates the chance of complications. Just
good old-fashioned human error.
Yeah.
Right. So here's a question, and it may be a marketing question, and I don't mean it to be that way at all, but when patients know that they have a certain surgery they need to have, where is the coaching and or the discussion, conversation with that patient of, are we gonna do this robotically? Are we gonna do it the old-fashioned way? I don't even know what the old-fashioned way is anymore. And I'm throwing that out to anyone who wants to take it. So when you're having a discussion with a patient, and let's say gallbladder, because I feel like you haven't had a lot of time, Chiba.
I was thinking about
So,
gallbladder.
were you really? Okay,
I
good.
was.
So someone has to have their gallbladder out. And and maybe this is perfect timing for you. What are the different ways to do that?
Yeah.
And what's your preference?
Right.
And do you suggest a preference to the patient? Like how is it that they come up with that decision?
Yeah, so there's two ways of doing it. One is the old way, which is open, which is you make a very large incision basically from your sternum to the bottom of your rib cage. And no one really does that anymore unless you really have to. And the standard is to do laparoscopic surgery at this point. And I let them know that robotic surgery is kind of an extension of laparoscopic surgery. So similar number of holes. They're all typically about 8 millimeters, except one incision is a little bit bigger, again, to take the specimen out.
Exactly.
Literally, the incision that we create is much larger than these stones that these patients have. So to the patient, it doesn't really make too much of a difference because the incisions are extremely small. And I just let them know that it's a type of laparoscopy and that it's using the robotic platform. And patients don't really have any issues with that.
And with recovery time, might that be something? I'd imagine everyone's interested in recovery time.
Right.
How much is it going to hurt? How much am I going to bleed?
Yeah.
How much recovery is there? What is that discussion?
Yeah, before open versus laparoscopy, open surgery with the gallbladder, taking out the gallbladder, they had to be admitted, a lot of narcotics. But with robotic surgery and laparoscopic surgery, I typically only give them very minimal, like 5 tabs of narcotic, and the rest is Tylenol Motrin.
Wow,
And I hardly
nice.
ever get a call saying, hey, can I have more? It's extremely rare.
Very nice.
So there, with all these narcotic reducing protocols, it's extremely important to do laparoscopic as well.
Excellent. Question here from the audience. The person on the line is 79 years old, had a hysterectomy at the age of 27, so very young, don't know what the circumstances were, had endometriosis. So Dr. Farnham, you get this question. So the way it's described, hysterectomy at 27 with endometriosis, oh my goodness gracious. Endometriosis to, it says here, to the rectum, so I don't know if that's how the surgery, and then ever since she has had issues with constipation, is there a surgery to address this? Again, there's a lot going on there, and this is a disclaimer that I didn't do, but I usually do. There's a lot going on here that we don't know. So we do the best that we can to answer, just respect her question and answer that. So what might your suggestion be to that question? There's a lot going on, sorry.
There's a lot going on.
Yeah.
And the severity of the disease would have to be pretty bad to have a hysterectomy, to have that type of definitive surgery at that age.
At that age, at 27, yeah.
I will say that endometriosis is mostly a reproductive disease. Now, there are certain case reports, I guess you could say, where there's active disease after menopause. But really, endometriosis thrives and grows in the presence of the normal cyclical hormone production.
So during reproductive years, so to
That's
speak.
right.
Okay.
So after menopause, there's a great amount of symptomatic relief, if not symptomatic resolution on its own. Now again, there are case reports, a few cases where it's still active after menopause, and actually it can be stimulated by hormone replacement as well. But we also have to keep in mind there are other organs in the pelvis, so this could be primarily a bowel condition, bowel cancer, irritable
Right,
bowel
could be a lot,
syndrome,
yeah.
diverticulosis, diverticulitis. It could be just the scarring that occurred from the original surgery could be causing some bowel symptoms. So
that's a good question there. If there is scarring, there is a way to remove scarring surgically. Or is there not? Again, this was done a long time ago. So, yeah. Bottom line is she needs to go and check out.
we need to have a workup, and
Right.
in all likelihood, a multidisciplinary workup. But based on the likelihood of someone having active endometriosis disease, like years and years remote from, decades remote from menopause, it's unlikely that that's the culprit. But there's going to be exams, studies, imaging, probably colonoscopy, different tests that can be done. And unfortunately for just scarring adhesive disease. When you take the adhesions down, lysis of adhesions, many times they just grow back.
Right.
So usually an intervention's not done for adhesion unless it's causing like a obstruction or an ileus of the bowel, it's actively affecting someone. And in those circumstances, they can become acutely ill quickly, fever, throwing up, and would necessitate a hospital visit. So.
Okay. Another question here from the audience. This kind of goes to urinary issues. You can have it again, or I'm going to give it to Dr. De La Rosa or Dr. Chiba, whichever one of you would like it. 67-year-old person, female, prolapsed bladder, again, after having a surgery 10 years ago for prolapsed bladder. Her question is, again, we don't know a lot, but her question is this something that you can redo again? I don't know what her age was when so 10 years ago, she was probably, 57, that's pretty young too. Is this something that, again, ligaments are ligaments, right? They're gonna stretch even more. So is that a common thing that you have the surgery once again? I'm just throwing that out to anybody too. Dr. De La Rosa, you haven't talked in a while, so that's kind of the way I do the ping pong table.
Yes.
Who hasn't talked in a bit?
Well, there's always a chance of recurrence after a pelvic support surgery.
Okay.
If you think about it,
Pelvic support surgery, that's how I should have worded it. Got it, yeah.
if you think about it, we're working with weakened tissue.
Right,
okay?
right.
So sometimes there's a lot of procedures we could do, a lot of different ways to fix things, and sometimes, or most of the time, we're working with weak tissue, so there's always that chance. It could deal with genetics, lifestyle, the mode of surgery we did. Some are more successful than others. Sometimes we have to help strengthen their tissue with the uses of meshes and stuff like that, but that's kind of, there's some other issues involved with that, but it is fairly common for ladies to come back for
And
a
that
second
does make
surgery.
sense to me. It's just wear and tear and stretching. And Dr. Farnham?
I mean, I think he's exactly right. I mean, you look at each type of procedure, success rates like a bladder lift by itself, 50%, a bladder lift with apical support with native tissues, about 86%, and a bladder lift with mesh, as Antonio was saying, probably about 92%. But, you know, I would also say, I mean, it's hard to study anything for more than 5 years. We have a couple trials that went out to 10 years, and success rates were still, 80s, something like that. But there are going to be recurrences, and it's like, you don't take your car in and you get an oil change and you're good for life. Or maybe in this case, a timing belt, right? Eventually, there's going to be wear and tear, and prolapse can occur around the repair that we already did.
Right, that's an excellent point.
So,
And I'm thinking too, because there's mesh, and so I'm thinking, is there a prosthetic ligament? But I guess that's what would be acting. The mesh would be acting as something that's actually lifting. And then here's my question: attaching. Where do you attach what to? Does that make sense? So if you've got the mesh, are you attaching it to the ligaments? I'm just trying to picture it. This is where I wish we had graphics and pictures to see it. But describe physiologically what's being attached to what inside the body.
so we'll talk about probably the primary repair is called a sacrocolpopexy, which is a mouthful, so we'll just call
Say
it
that
sacro.
really slow. Okay, gotcha.
So it was 3 words, so sacro, sacrum, colpo, which is vagina, and pexy means tie together. So
Gotcha,
sacrocolpopexy. All
Got
right.
it.
So we introduce a safe mesh, type 1 polypropylene mesh, extremely low risk of erosion, infection, pain. We'll take a quick aside. So there was something called vaginal mesh, and had a lot of complications. 11% approximately need for reoperation, whereas a normal reoperation rate is about 1%, so a lot higher.
Right, right.
And that, there was a stop sales and manufacture order from the FDA in 2019, so that's not available. So anybody who's wondering, you couldn't have it if you wanted to have it, okay? This surgery, sacrocolpopexy, has been around for 6 decades. So this is a very proven therapy with erosion rates 1 to 3%, very low, and then recurrence rates, like I said, about 8%. But what happens is we introduce it's kind of a Y shape. One arm of the Y goes to the anterior aspect of the vagina in front of the bladder. The other end goes posterior or back side of the vagina in front of the rectum. And then the third arm of the Y is attached to something called the anterior longitudinal ligament. So it's just it's the strongest ligament in the pelvis. That's why we use that one. And it's kind of on the, if you think about your spine, and then there's bone, and then there's ligament on top of that. So the transition between your lumbar and sacral spine, L5S1. There's a very strong ligament there. And anatomically, that pulls it in the exact direction it needs to be in. And so
next time we do this show, you guys have to bring pictures.
yeah, I was hoping we'd have
Without
Thomas here or something.
question. Yeah, this is, because it does make all the sense in the world, because you're thinking, or at least I'm thinking, there's all the organs are in there, and they all have their special place. And on that note, too, there was a individual in my office that had a hysterectomy, and the idea was, and she visualizes it like this, because her doctor described, well, now that the uterus is gone, now the organs that were kind of pushed aside by the uterus need to find their space. And Dr. De La Rosa, we talked a little bit about that earlier. How do I ask that? That's not a recovery period, but how long does it take for your abdomen, or Dr. Chiba, maybe you can talk about that, to find its new normal with the space that is now missing?
It's pretty much immediate.
Okay.
Now there's going to be different sensations right after surgery.
There's like that the compression belt though that she was wearing for a while, and like maybe explain that.
I think a lot of that comes from the surgery itself. We're cutting, we're cauterizing tissue. There's going to be inflammation. There's going to be pain involved. A lot of the sensations they feel are due to the surgery. The bladder lies on top of the uterus, so when you remove the uterus, the bladder kind of
is hanging out there
a little bit, and you have changes in your urinary stream, sometimes changes in how you defecate. A lot of ladies think that they're going to feel hollow because an organ that was there wasn't gone, but if you think about it, your intestines are shifting all the time. If you lie on your side, they're going to lie one way, you turn around the way they come, so you just kind of fill in the area.
Okay, and then they think there's a little bit less there to deal with. We're kind of at the point where I'd like to just not ask questions from the audience anymore, but see what each one of you want to talk about before we get off the air, because we've got about 7 or 8 minutes or so. So Dr. Shiba, I'm going to start with you, because I feel like I haven't asked enough questions of you, and we did focus a lot on OBGYN stuff, but in general, is there anything that maybe as you're driving over here, maybe I shouldn't, because he's not the veteran. That's not fair. You know what? You don't have to go first, because I hate that. In the school, Dr. Farnham, you get to go first. Is there anything that we haven't talked about yet that you'd like to get across before the end of the program?
We could talk about like where we see ourselves going in the future with robotics, and is there going to be a time where there's no doctor?
Don't say that. That freaks me out. I think that's going to freak everybody else out.
Aliens movie, yeah.
Stop.
But no, I think it's a process of automation creep. If you think about with a car, you had like adaptive cruise control, and then rain sensing headlights, and you can sense the lanes that you're driving in. And all of a sudden, we have a self-driving car. But was it really all of a sudden? It wasn't. There were all these little adaptive things that occurred over time, and that's kind of what we'll see with robotic surgery. And at the heart of it, even with AI, machine learning, deep thought, it's going to be really hard to replace a surgeon's intuition. And so
that's where the intuitive question came in earlier. It's like, what does he mean by that? I'm not sure. Intuitive robotic surgery.
But it'll become more and more things that we do in the surgery will be automated, but it will be to make what we do better, just as the robot makes surgery better compared to laparoscopic.
Okay, makes sense. Now, Dr. Chiba.
Yeah.
Now you're on the spot. Okay.
Yeah, I know we're talking about robotics here, but I really think that not all surgery should not be done robotic. There are some cases where they come to me and say, hey, I want robotics for this. But I say no. For this specific case, open surgery would be the best choice. So I wouldn't say that, if they go to a doctor and they say they don't offer laparoscopic surgery or they don't offer robotic surgery, I don't think it's not in the wrong for them to say that, I think. I don't want everyone to say, oh, I only want robotic surgery, because
it's
case
excellent
by
point.
case. Yeah.
Right. So on that note, as an abdominal guy, what surgeries would be best not to do robotically?
Well, that really depends.
There's a lot in there.
Having said that, I do majority of my surgery robotic.
You just think the abdomen, there's like everything in the world in there. You've got kidneys, you've got livers, you've got, the duodenum, you've got all kinds of stuff in there.
Yeah, I think the easiest example is hernias,
Right, okay, good point.
Majority of the inguinal hernias I do laparoscopic, but there are we have this UMC and trauma center, and they have a large incision. They've had 5 incisions in the past. That patient is not a candidate for
Right,
robotic
good point.
surgery. In fact, robotic surgery may be a little bit more dangerous for the patient. So it's case by case.
Okay, nicely put. Dr. De La Rosa, anything before we wrap up?
Well, one way of dealing with that, the complicated things, I think a lot of us will do laparoscopy, insert a scope, and see if it's something that could be done. Most of, well, at least I'm talking in my specialty, the GYN surgeons. I know most of the ones I've gone to a lot of conferences, seen the experts, and most of those experts are all in, meaning they'll do anything. I mean, it's worth a try. Of course, you're not going to do anything dangerous where you're going to put the patient, but let's say the big giant uterus. A lot of times,
I love how you say that, the big giant uterus.
yeah, you look at it, you
lingering
think
out there.
it can't be done, but sometimes you're able to successfully do it. And me personally, some of the cases I've converted, even though I've had to convert, they still got a benefit from the robotic surgery, because instead of having to make a big incision from your pelvis up to above your belly button, I could detach the part of the uterus, and it lets me use a smaller incision. Even though I still opened, it's a smaller incision that I needed to use compared to if I would have just done the whole case open. So even in those cases, there's somewhat of a benefit.
And every time I hear smaller incision, to me, that's less recovery time, less, I don't know, idea for infection. We've got a whopping 45 seconds. Let's talk about infection rates really quick. And Dr. Farnham, you're on for that, regarding how small the incisions are and recovery time.
So we published the largest retrospective study on hysterectomy in 2016. And in our 7 case observation centers, we showed that the surgical site infections were less with robotic compared to doing it any other way, hysterectomy, laparoscopic, vaginal, or open.
Okay. And that, again, it just makes sense. The smaller the incision is, and the cleanliness of it, too. I mean, we're looking at less stuff in the way. So we have less than a minute, so I don't have enough questions or enough time to ask another question, but I do want to say thank you very much. What I do want to do again is you can watch this program again. Sometimes things go so fast, you may have tuned in late. pbselpaso.org. You can go to that site and just look for Watch and El Paso Physician. You can also go to the El Paso County Medical Society website. Just think of that acronym, epcms.com, and watch this program again. And you can also watch it again via YouTube, and usually you can find that under El Paso Physician. And honestly, there are quite a few PBS stations around the country that air this show, which is great because the word's El Paso in there. But thank you very much to Dr. Farnham, Dr. Chiba, and Dr. De La Rosa. And a big thank you also to Gracie and Valeria, who have been helping out with phones this evening as well. You've been watching the El Paso Physician. I'm Catherine Berg, and have a great evening. Good night.